And my initial reaction now is that I know that at least the MB Canal, these files at the end are quite bent, and I don't want to fracture these files. So I'm going to be very, very, very careful removing the MB file. And we can see when we pull them all out, we have a little look. They're really, really bent at the end. And I'm really, really lucky to remove those files without fracturing them. Hello, so welcome to this week's Friday clinical case. And well, I was in two minds whether I should post this case today because I'm not really proud of it. But the overriding reason why I wanted to post this case, because I think it'll just be a really nice learning experience. And essentially, this is where the apex locator, or the function of the apex locator has broken down and it's not worked for one reason or other. I think it might be because there's just a significant lesion around this tooth, and that's the reason why it hasn't worked. Although, you know, sometimes, purely anecdotal, I do find that some patients don't respond very well to apex locator use. I don't know if they've got a different type of resistance within themselves or whatever. You know, if you do know the answer to that question, put it in the comment section below. But before we get into the case, before I present the case, I want to say over 50% of the people who watch these videos are non-subscribers. So if you could do something for me, it's quick, it's easy, and it's free, and that's just to hit the subscribe button. If you hit the subscribe button, it pushes the channel along, it supports the channel, and of course, if you want to support the channel even further, we've got a membership program that's run by YouTube. It's a small monthly fee. You get early access to content, and also you get exclusive content. We've got a fantastic endodontic access video on there that's just for members only. So we'll get into the case. So this is an upper right 6, and this is an external referral. This is a patient who's been referred to me from another dentist, and they have recently had a crown fitted. And when I say recently, within the past 12 months, the patient had started to suffer symptoms. A periapical radiograph was taken. It was found this tooth was necrotic and had a chronic apical periodontitis apically in this tooth. So when we look at x-rays like this, we look at a number of things. First of all, we can see that the crown itself looks pretty good. It's been placed quite recently, so we're not really going to be asking the patient to have this crown removed and replaced at their cost, you know, to complete the root canal. So in this case, we're going to just drill through the crown, make a small hole in the top of the tooth. This, of course, brings down the cost for the patient, but also increases the risk of perforation, because obviously you need to know where you're drilling, and it's really easy for you to sort of orientate the drill in the wrong direction and sort of cause a hole where a hole shouldn't be, as I like to say. Another thing I noticed with this tooth is that I feel like the roots are quite long. Now, this was my initial reaction to this tooth. However, it transpires as we get on with the case that this isn't true. But I suppose in a way, the reason why I got myself into the situation that I did with this tooth, i.e. pushing the files too far out the end of the apex, is because I had that sort of initial assumption that this tooth was long. Also, given the fact on top that the apex locator reading wasn't showing 0. So sometimes, and what happened to me during this case is I got like a kind of a strange gut feeling that things weren't right, and then we sort of changed tack. So let's move over to the case. First of all, of course, we're always going to be placing rubber dam. In this case, I'm just going to do single tooth isolation. You know, I used to cut access cavities in crowns with the rubber dam off. Now I feel like I've got to the point where I just think it's easier with the rubber dam on. You know, we make a small bit of access cavity in the top of the tooth. We just see where we are, and we just do a little bit of refinement. And we notice straight away we get a small pinprick exposure of this pulp chamber. So we're going to use this pinprick exposure as kind of our sort of access point to try and refine the access cavity. I do use an ultrasonic tip, a high energy ultrasonic, just to open this up. We can see now that the ultrasonic has widened the access or the pulp chamber, but it does have its limitations. So in this case, I'm going to use this Endo-Z burr. This is a fast friction rip handpiece burr, just with a blunt blunted end. So I'm just going to sort of waz it around and open up the pulp chamber roof without risk of drilling into the pulp chamber itself. And I do have a little feel around with my size 10 D finder here, but I just feel like I'm not getting even close to the orifices, so just need to do a little bit more refinement. In this case, I'm going to use just a normal burr because I feel confident in doing so. And then, of course, once we've opened up the access cavity, I'm just going to give it a bit of a clean out with our ultrasonic again. And we can just see that it just looks like a solid block of dentin down here. The pulp chamber isn't as open as I'd like it to be, and when we have a sort of a bit of a clean out, I do notice decay within the pulp chamber itself. And also this is probably sort of organic material as well. So to remove this decay and this organic material, I'm going to use a rose head burr, just a normal one now, not a long shanked one. And when we sort of clean this out, we obviously use a little bit of fast handpiece, a little bit of ultrasonic. We can see now that the pulp chamber is looking much more clean, and we can actually see the floor of the pulp chamber. We can see the floor, which is darker than the walls. The walls, you can see, they're all quite white. And then the final kind of refinement here is just using my low energy ultrasonic diamond tipped burrs here, and I'm just basically opening up the canal space, opening up the pulp chamber. I am sort of looking to sort of remove any kind of overhanging dentin, which is going to be sort of covering the pulp chamber, the canal orifices, because obviously what we want here is we want straight line access. I am also going to have a tiny little feel around for maybe where the MB2 might be, or maybe, and I'm just kind of just getting the lay of the land. I'm just having a feel about where the DB might be, where the MB might be, and it's also kind of a good kind of, we could call it a stock check. We could just see where we're at before we sort of jump straight in to the root canal shaping itself. And what I do notice with MB canals is they can be kind of tucked really far up into the mesobuccal cusp. So using these ultrasonic tips, you can kind of open up this kind of this orifice ready for our shaping and our working length check. So a bit of a clean out, and we can see here now that we've got obviously 3 orifices and there's a small suggestion of an MB2. So we're ready to essentially shape. What I am first going to do is, unusually, I'm going to go down the DB, the distal buccal, and then I'm also going to feel down the MB, and I feel like I'm not really negotiating well enough down these canals at the moment. So I'm just going to use a size 15 glide path file just in the sort of coronal to mid third of these canals, just to open up the canal spaces ready for our negotiation. So, using a size 15, I believe this is an 04 or an 03 from HighFlex, and we can see now that all of the orifices are now nice and open. So we use the glide path in the palatal as well. So I'm going to try and take a working length of the palatal, and when I sort of hook up the apex locator to this size 10 D finder, and I negotiated it down to sort of almost up to the shank, to the 25 millimeters with this file, we're not getting 0 at all. And when we look at the X-ray here, again, I'm thinking to myself, this tooth looks quite long. So what I need to do is I need to pick up a size 31 K file instead. So this is normally files are 25 millimeters in length. This one's 31, and then as I again hook this size 8 now up to the apex locator, and I'm kind of reaching further and further in, there's no 0 at all. So at this point, I'm just thinking, this tooth's just really, really long. I need to just, use my bit of patience. Again, I'm going to just do it in the DB, still not getting 0 at all. In this case, I'm just going to move the stopper up to this kind of reproducible point, and then when we have a little measure in for the DB, we can see that the furthest we've got is 21 millimeters. So I'm going to use that kind of step back approach. In this case, we're going to use a size 15 glide path file, and then we're going to shape the DB with a size 25 up to about 20, so about a millimeter away from the furthest point reached. So I'm going to make a very, very small bend at the end with this size 31 hand file, negotiating the DB, because obviously I've opened up the canal space, but also there might be a little bit of a bend at the end. Again, we're hooking it up to the apex locator, and I'm still not getting anywhere near zero. So we're not even sort of even close. And again, this is sort of ringing alarm bells in my mind, and the furthest point reached here is 22 millimeters. So I'm going to try and use a different tack here. I'm going to use a size 8D finder. So it's a little bit stiffer than a long file. We're trying to negotiate that down to length. We measure it, and again, we're getting about 23 millimeters furthest point reach. And then we're just going to do that side kind of process of seeing how far we can get, shaping about 1 millimeter away with these higher diameter files, having a little negotiation. Again, I am feeling a stop in this DB, so I feel like I'm not getting anywhere at all. And then finally, we're just going to use this size 6 C+ file. These are end cutting, so you just got to be super careful with these, and also you've got to be careful you don't fracture these. And the size 6 C+ file actually reaches past the furthest point reach with all the other files. So this is going to about maybe 24.5, 24 millimeters in length. But when we hook it up to the apex locator, we are not getting anywhere near zero. So I'm just having a little tiny feel, bit of a watch wind again. I'm really, really worried about fracturing this file dead easy. And we hook it up, no zero. So again, ad nauseum, we're just going to be doing that step back approach. We got to a size 6 in the DB. I'm going to now use our step back approach using an 8 and then a size 15 to try and open this up. And I would say 9 times out of 10 when you use this approach, you do actually reach zero. I'm getting slightly worried now. I'm worrying, thinking to myself, I'm getting no zero. I'm not reaching to the end. Maybe I'm not going to be able to get patency in this canal. So we'll give it a good old clean out with EDTA in this case. And when I'm not reaching to length, EDTA sometimes can open up the canal space, especially apically. And after we've let the tooth soak with EDTA for quite a long time, I'm going to go back in with my size 831 K file, and it is reaching even further this time. So I'm getting an 8 now to about 25. But again, we hook it up to the apex locator, and again, nothing at all. Maybe we've got a little blue line there, so we're getting a little bit more. But again, furthest point reach is 25 millimeters. And I'm going to have a last go down the MB because I've not reached zero in the palatal. I've not reached zero in the DB. We have a little feel around with our MB file. Again, we're getting really, really far with this MB. We're getting almost to about 28 millimeters. We're hooking this up to the apex locator and nothing. And when we look at the end of this, we can see that it's kind of bent at the end. And my initial reaction to this is that because it's bent, there might be sort of some sort of anatomical complexity. And when we find anatomical complexity, the apex locators don't tend to work very well at all. So at this point, I'm thinking to myself, with the MB, we're getting to about 27 millimeters. I just need to take a working length x-ray. So we get 3 31 length files, size 8K files, and we push it to the points where we think, or we're sort of making a suggestion that we're the furthest point we've reached. And then when we take the x-ray, bit of shock horror really. This is frustrating because we are way past the working length in the palatal, in the MB. We're slightly past the working length in the DB, but we're super too far. And my initial reaction now is that I know that at least the MB canal, these files at the end are quite bent, and I don't want to fracture these files. So I'm going to be very careful removing the MB file, and we can see when we pull them all out, we have a little look. They're really bent at the end, and I'm really lucky to remove those files without fracturing them. So we're going to have to go back to basics with our working length x-ray. What I am going to do is I'm going to kind of make a guesstimation. I'm going to go on the computer. I'm going to just sort of measure, make a kind of an estimation of what the working length is, and then we're going to use some higher diameter ham files, size 10s, and we can see here that again, annoyingly, I have placed 2 files down the same canal, down the DB. transpires that it's quite short, and also the palatal is also quite short. And then I think to myself, maybe it's my apex locator that's not working very well. So I get the Practices apex locator. This is a woodpecker one, a DT one that works pretty well. And I'm also using a higher diameter file. So I'm using a size 15K file here. And it's known that using a higher diameter file, especially a size 15, the apex locator gets a more accurate reading. And again, same with this apex locator. We're reaching to that point where I know we're through the apex and we're not getting any reading at all. So this kind of solidifies my approach in this case, is that I know that I've used a different Dimes ham file, I've used a different apex locator, and we are not reaching the correct working length measurements with these apex locators. So I'm going to have to do it a more traditional way in this case. So we're going to have to really rely more on our radiographs rather than our apex locator, which is really, really frustrating, really, because I know that using a radiograph it isn't the best way to gain an accurate working length. I suppose in a way you could argue that I could just dress the tooth and get the patient back in, but then there's that risk, of course, that the patient comes back in and the apex locator still doesn't work. So I make a command decision here, is to try my best, and the patient, of course, all the way through this has consented. While the x-rays are going through, I'm telling them that I can't get to length, etc., etc., etc. So I'm going to take another working length x-ray. In this case, I'm going to use the size 15 in one of the canals, I believe is in the DB, and I'm going to place a size 10 in the palatal. And we can see here that I'm still looking a little bit too short. So I'm going to shape up to this point. So I'm going to shape up my my rotary files up to the point that I got with these with these ham files, and I'm going to place my GP cones now to length. And again, this is all about taking the working length. And when we look at the first cone fit radiograph, in this case, we can see that the DB is pretty much the length, the MB is a little bit short, but pretty much nearly there, and the palatal is looking a little bit too short. So we're going to do that kind of guesstimation again, where we take that x-ray on the computer digitally. We're going to make a couple of little measurements on the computer. Again, it's not ideal, but it's the best we've got. We're then going to do a bit more shaping, and then when we take another cone fit radiograph, we can see now that we're pretty much there and to length. So not the ideal situation, but it's better than nothing. So I'm happy with these working lengths now. We're going to remove the GP cones. We're going to place them in the disinfectants. We're then ready to find our MB2. So loads of drama, and now I've got to find the MB2. So I get my low energy ultrasonics in this case, and I'm just going to have a feel around for the orifice in the MB2. Initially, when we access the tooth, I saw kind of like a depression within the sort of palatal shelf. I'm going to sort of expand on that and have a little look around, and we can see there's definitely an orifice here. Can it be negotiated? Well, that's a completely different story. So first of all, I'm going to use a size 8 define. This is just going to negotiate down. I get a little bit far, but not too far. And what I like to do is I like to use a glide path file in this MB2 to about 1 millimeter away from the furthest point reached. Lots and lots of irrigation, lots and lots of cleaning. And then as I irrigate and aspirate out of this MB2, I can probably see that maybe the MB1 is irrigating and aspirating too. So, if you're a member, if you know the channel really, really well, you'll know I like this kind of GP marking trick. So I'm going to place a GP cone into the MB1 canal, and I'm going to place my size 8D finder in the MB2, and I'm going to try and negotiate as far as I can with this size 8D finder. And then if the two canals join, as they do, they make a small little mark at the end. And then it's at this kind of point where we know to shape up to. And of course, you don't really need to use the high diameter files. In this case, I know that I can. And overall, we're ready to do our obturation. And, you know, with obturations like this, what I know that I struggle to get to the end, and maybe I might be a little bit short. So I'm going to use a little bit of hydraulic condensation or compaction with our bioceramics, and we can see with the obturation here that we've got to length. The palatal was slightly short, but we've got that kind of doming over of the bioceramic. So not the greatest PA either. So yeah, I like to think that with the channel, I like to show all of my cases, the good, the bad, and the ugly. And I think this is a really, really difficult case. And I suppose, you know, me as a dentist 10 years ago probably would have had this tooth out or referred this tooth. But I think we've done our best for the patient. And also what's really, really important is, of course, the patient's had a consultation. All of this has been explained to them prior to this. They're aware that there's a possibility we don't get to the end or we have trouble, and the patient's been consented all the way through it. They're happy to carry on. And overall, great result. Thanks for watching. If you have any comments or criticisms, please comment in the section below. Again, if you haven't subscribed, please subscribe, and I'll see you in the next case next week. Bye-bye.